Rectal cancer is a subset of conditions referred to as colorectal cancer or large bowel cancer. Generally, within colorectal cancer, we include both colonic malignancies, rectal malignancies, and miscellaneous other growths that we'll discuss later. The focus of this presentation is on rectal cancer. Anatomically, the rectum appears to be a simple continuation of the colon. However, while it anatomically commences at the rectosigmoid junction, there are aspects to this that make it distinctly different in terms of its behaviour from colonic cancer.
The true rectum represents the lower 2/3 of the rectum, below an anatomical distance of about 11 to 12 centimetres from the dentate line, and generally speaking represents that area of rectum that sits below the peritoneal reflection in the pelvis. While most of the colon itself has a distinct mesocolon within the pelvis, because of the anatomical constraints of space, this consolidates into what's referred to as the mesorectum, which is a bulky collection of fat, connective tissue, blood vessels and lymph nodes sitting behind the anatomical rectum.
The behaviour of rectal cancer is fundamentally different from that of colonic cancer. Generally, colonic cancer, if it metastasises, does so in a predictable fashion, firstly to loco-regional lymph nodes and then to distant lymph nodes or other organs, and hence after resection of the colonic cancer, the only real consideration is the risk of metastatic relapse with distant metastasis. However, with rectal cancer, there are substantially more anatomic structures packed into a small space, and hence there is a definite risk of local relapse or disease failure after resection of an extraperitoneal rectal cancer. This significantly alters our management protocols for rectal cancer compared with colonic cancer.
Whilst colonic cancer tends to present with large bowel symptoms, rectal cancer will often present with more localised symptoms, such as bright rectal bleeding, pain, tenesmus, change in bowel habit or mucus loss. The symptoms can be very similar to those of perianal pathology, such as hemorrhoids or an anal fissure, so it's critically important in all patients with rectal symptoms that consideration is given to performing colonoscopy, tailored of course to the needs of that particular patient. Rigid sigmoidoscopy is now much less commonly performed than perhaps 15 years ago, as the preparation is often poor, visualisation can be difficult, and it's often poorly tolerated by the patient. Importantly, in a patient who presents with rectal symptoms or rectal bleeding, even if they do respond to conservative management, consideration should be given to either colonoscopy or at least fecal occult blood testing after complete resolution of symptoms. If in any doubt, a specialist opinion should be sought.
The National Bowel Cancer Screening Program has been well established in Australia now for several years and obviously incorporates screening for rectal cancer. In asymptomatic adult patients, they should be stratified for risk on the basis of their family history and their personal medical history. In those that are asymptomatic with low to normal levels of community risk, fecal occult blood testing should be performed every 1 to 2 years from the age of 50 or 10 years earlier if they have a family history. Colonoscopy is only needed for people that are considered category 2 to 3 risk, which is a family history of first-degree relatives under the age of 55 or multiple relatives affected.
The mainstay of diagnosis for rectal cancer remains a colonoscopy. A well-performed colonoscopy with representative biopsies of any identified lesions, and preferably with tattooing of those lesions, should be the first diagnostic step. As with any colorectal cancer, this should be followed by a CT scan of the chest, abdomen and pelvis to exclude distant metastatic disease. Because of the risk of local relapse in rectal cancer, and therefore the different treatment protocols, it's essential that local staging is performed of the rectal cancer as well. Generally speaking, this will entail an MRI scan. The MRI is now reasonably cheap, readily available, and has proven efficacy in establishing both the tumour and nodal status of the rectal primaries.
Rectal cancers are generally assigned a T stage from 1 to 4, where 1 and 2 are localised and have penetrated into but not through the wall of the bowel. A T3 lesion has penetrated through the wall of the bowel into the adjacent soft tissues or mesorectum, and a T4 lesion has definitively invaded adjacent organs or has reached up to the peritoneal reflection and into the peritoneal cavity itself.
Nodal status is also estimated from the preoperative MRI. The MRI is more an estimation of the nodal status in the sense that, of course, it can't obtain a tissue diagnosis, but it reports abnormal looking nodes rather than definitely positive metastatic nodes. The nodal status staging system is much simpler, and the nodes are deemed to be positive or negative. Any positive node represents N1 status.
In terms of clinical management, we will focus initially on discussion of patients whom curative intent is sought. Obviously, if preoperative CT scanning shows evidence of distant metastatic disease beyond local pelvis or nodes, then the patient has stage 4 disease. For patients with stage 1 to 3 disease, preoperative tumour and nodal staging largely defines the management protocol. If a patient has T1 or T2 tumour invasion, that is, it's contained within the wall of the rectum and no nodes are involved, then generally speaking, current treatment protocols dictate the patient should proceed directly to surgery.
If patients have evidence of T3 or T4 invasion through the rectal wall into surrounding soft tissues or adjacent organs, or if there is evidence of abnormal nodes on preoperative staging, then we would regard the risk of local relapse disease as being significantly elevated, and current treatment protocols would dictate that this patient is offered the option of preoperative neoadjuvant chemoradiation followed by surgery. Usually there's a hiatus of 6 to 12 weeks after the completion of chemoradiation. It's important to note that all of these patients, when treated at Cabrini Hospital, are routinely discussed in a multidisciplinary meeting involving medical and nursing clinicians from all areas involved in the management of rectal cancer. Whilst the treatment protocols outlined above are regarded now as standard of care in Australia, obviously the treatment needs to be individualised to the patient's circumstances. If a patient has a very significant comorbidity or is very elderly, they may not be prepared to undergo or tolerate chemoradiation and may proceed directly with surgery. Obviously, the technique of surgery, a more challenging and prolonged procedure with the aim of reconstruction and avoiding a permanent stoma, would be appropriate in a younger, fitter patient, but may not be appropriate for patients who are older with comorbidities or have poor sphincter function preoperatively. Medical workup is an important part of the preoperative assessment of these patients, and if, for example, a patient has significant cardiac issues that would require resolution prior to surgery, there are times when we would lean towards preoperative chemoradiation treatment to allow a window to deal with, for example, a critical cardiac stenosis that requires stenting prior to surgery. The cornerstone of this, however, is still a thorough workup, an extensive discussion with the patient, and multidisciplinary discussion prior to making a final decision about treatment protocols.
So chemotherapy is used in 3 situations in rectal cancer. The first is prior to surgery in combination with radiation therapy. This is called neoadjuvant therapy, and during the period of radiation therapy, chemotherapy is administered concurrently. The aim of the chemotherapy is to radiosensitize the tumour, making it more sensitive to the kill of radiation treatment. The second indication is adjuvant therapy. So adjuvant therapy is basically given after surgery with the aim that it will reduce the risk of developing distant metastases. We usually don't determine whether patients have adjuvant therapy after rectal cancer until they've had their surgery and we have a good idea as to the pathology both of the primary tumour and the regional lymph nodes. If a patient has a complete response to chemoradiation, there is reasonably good evidence now that post-operative adjuvant chemotherapy is not warranted. On the other hand, if they have clear evidence of nodal disease, they have very high risk of distant metastases, and that risk will be reduced by chemotherapy. So it's been shown that adjuvant chemotherapy reduces the risk of recurrence and improves overall survival. The third indication for chemotherapy is in stage 4 disease. Most people that have stage 4 disease are deemed incurable, and their treatment is therefore palliative. There is a whole range of chemotherapy drugs and combinations of drugs that can be used in this situation, and it has been shown that the use of these drugs has extended the median survival from only about 6 months prior to chemotherapy being used to well in excess of 2.5 years. Patients, particularly that have stage 3 disease, which is node positive disease, have a significant risk of developing distant metastases. It's been shown that post-operative chemotherapy will reduce that risk. There are a number of different combinations of treatment that have been used, and basically most of the studies have shown that the benefits of the different combinations is about the same. The standard treatment we use at Cabrini, and most places will use, is an oxaliplatin-based chemotherapy that combines with a drug called 5-FU and leucovorin. This is often given for 4 to 8 cycles over a period of about 16 weeks. It is usually well tolerated, although patients can develop some peripheral neuropathy. So the usual side effects of chemotherapy fit into 2 categories. There's the general or constitutional side effects, fatigue and muscle weakness that will occur, and that tends to be a cumulative effect. And then there are the specific effects that occur because chemotherapy affects cells that divide rapidly. Those side effects include things like stomatitis, which is mouth soreness or ulceration, diarrhea, which particularly will occur in the first few days after treatment. Also myelosuppression, particularly reduction in white cell count. And there's a specific toxicity, peripheral neuropathy, that occurs with one of the drugs we use, oxaliplatin. With regards to recovery from the effects of treatment, the timing is different for all of them. Particularly with regards to white cell recovery, it has to occur prior to the next cycle of treatment. With regards to most of the other side effects, they tend to occur once the treatment has finished, although peripheral neuropathy to some degree can be permanent.
Radiotherapy in rectal cancer primarily is to improve loco-regional control, and in some studies has also shown a survival benefit. This may reduce the risk of recurrence in the order of around 2/3. It also has a role in other cancers of the colorectal tract. An example of this is in anal cancer. This is typically a different tumour, commonly a squamous cell carcinoma, and in this setting it's used as definitive treatment in combination with chemotherapy. This has shown high rates of loco-regional control, often above 80%, which translates into a survival benefit of the same.
Abdominal resections for rectal cancer are a major physiological challenge for any patient, regardless of age. And so every patient, prior to consideration of surgery, should be properly assessed for the presence or absence of significant comorbidities. And if necessary, we recommend a full workup by a perioperative physician prior to surgery. If there are major health issues that need to be addressed, including potentially reversible cardiorespiratory illness, there is compelling evidence that resolving these problems prior to surgery leads to an improved outcome for the patient, even if it means delaying the surgery by some weeks or even months.
If patients undergo neoadjuvant treatment, then timing of surgery afterwards is generally between 6 to 12 weeks to allow adequate tumour kill, shrinkage and resolution of acute tissue damage that will inevitably occur through local radiation of the pelvis. Generally, this time lies between 6 to 12 weeks, but again, it needs to be tailored for each patient. For example, if there is a large, bulky tumour, we occasionally wait longer to allow full shrinkage with regular reassessment in the rooms by the surgeon and treating team.
Occasionally, the patients will require re-imaging or repeat colonoscopy prior to the procedure to assess the local response to chemoradiation. Surgery can be deferred longer if patients have comorbidities that require management beforehand. Patients with a significantly elevated BMI are encouraged after completing their radiation therapy to try to maximise their physical fitness and to approach normal body weight as closely as possible. So occasionally again we will defer surgery to allow this to occur if the patient is succeeding in their endeavours. Treatment of a rectal cancer requiring an operation through the pelvis is significantly hindered if patients have an excess of intra-abdominal fatty tissue. So we do encourage patients to present for surgery at normal body weight if at all possible.
The aim of surgical management of all patients with rectal cancer is, where possible, to use a minimally invasive technique, minimising the risks of the patients post-operatively and improving their functional outcome and avoiding a stoma if at all possible. Regardless of comorbidities or sphincter function, avoiding a stoma requires a sufficient margin of normal tissue below the tumour to allow reconstruction with an intact pelvic floor and anal sphincter. Generally, if a tumour is above the lower third, unless there are particular technical difficulties, a permanent stoma can be avoided. Once the tumour enters into the lower third, matters become much more complex, but there are options for reconstruction in patients, even with lower third tumours, particularly if they respond well to chemoradiation and the tumour is not particularly bulky. A stapled ultra-low anastomosis can be achieved in many patients with lower third rectal tumours, and this can be performed either as an open technique, laparoscopically or robotically. If the tumour directly impinges on the sphincter mechanism and an adequate margin cannot be obtained using any of the many surgical techniques available, then abdominoperineal resection with an end permanent stoma may be required. It is important to note, and we do educate patients to this effect, that quality of life studies of patients with a well-formed stoma with appropriate education and support indicate that patients can maintain an excellent quality of life with a permanent stoma. Despite this, of course, the inclination is to avoid a stoma where possible. If there is a very small margin between the tumour and the sphincter mechanism, there are specialised techniques that can be used to aid in reconstruction of some of these patients, including a transanal dissection with a hand-sewn coloanal anastomosis. This in particular may be suitable for patients with excellent preoperative function and an adequately functioning sphincter. When dissection has been performed above, the blood supply to the lower third of the rectum is often not as reliable as more proximally up the large bowel, and hence it's well recognised that the risk of anastomotic leakage increases as the anastomosis is placed closer to the anal sphincter. Therefore, a significant proportion of patients with lower third rectal cancers, particularly if they've undergone preoperative chemoradiation, will be offered the option of an elective loop ileostomy at the time of the surgery. The purpose of the loop ileostomy is to divert the fecal flow away from the healing anastomosis, and it is generally left in place for about 8 to 12 weeks after surgery, although this is of course tailored to the individual needs of patients depending upon how quickly they recover from their surgery. In patients for whom post-operative chemotherapy is required, then often we'll defer closure of the stoma until the chemotherapy is finished. Importantly, closure of the stoma is not nearly as significant an operation as the original resection and generally involves a small transverse incision through the abdominal wall around the stoma without a full and extensive laparotomy. So the second stage of their surgery is far less challenging for the majority of patients than the first. The treatment protocols we've outlined above are for patients with an established and invasive rectal cancer, and most of these patients present with at least T2 disease. However, a small percentage of patients will present with early stage disease, or disease in which definitive evidence of invasion cannot be obtained. A small subset of these patients with either T0 or early T1, or very occasionally even limited T2 disease, can be treated by local transanal surgery. The indications for this are reasonably limited but include advanced polyps, small T1 carcinomas of the rectum that are lymph node positive, or occasionally small T2 lesions in patients with comorbidity or who are at significant risk of abdominal surgery. For T0 lesions or advanced polyps, where there's no definitive evidence of invasion, then of course there's no risk of metastatic disease. So if the lesion can technically be removed transanally, then that's perfectly adequate. For patients with invasive cancer, without doubt, the most oncologically appropriate treatment is removal not just of the primary lesion, but of the associated lymphovascular chain, that chain being associated with the rectum, that is with a transabdominal resection. But in a highly selective group of patients with favourable early T1 lesions, transanal excision can be performed with a reasonable degree of safety, and certainly with less physiological stress than that required after a transabdominal operation. There are numerous specialised techniques of transanal surgery, but probably the most commonly used technique at Cabrini Hospital is transanal endoscopic microsurgery, or TEMS. The introduction of laparoscopic surgery to gastrointestinal surgery in the early 1990s has revolutionised our approach to the treatment of bowel cancer, particularly in the last decade as techniques have become refined and instrumentation has improved. For most colorectal cancer, now, a laparoscopic approach is the indicated mode of resection and can be performed in more than 90% of all colorectal cancer resections. For colonic cancer, there's been impressive evidence over a long period of time now that the laparoscopic approach to resection will offer improved post-operative outcomes, a reduction in blood loss and requirement for transfusion, and oncologically equivalent cancer outcomes. The situation is not so clear-cut, however, with rectal cancer. There's currently a range of minimally invasive approaches for the treatment of rectal cancer, including laparoscopic, anterior resection or APR, robotic surgery, transanal, total mesorectal excision, and other techniques. The results of these different techniques and long-term outcomes are still in the process of being established, but suffice to say that the majority of patients with rectal cancer at Cabrini Hospital will be offered one of these options of minimally invasive surgery if it's deemed appropriate. Importantly, every patient undergoing colorectal cancer treatment at Cabrini Health has their treatment and outcome data entered into both the Cabrini Monash colorectal neoplasia database and the binational colorectal cancer audit of the Colorectal Surgical Society of Australia and New Zealand, ensuring quality assurance for all of these patients. Cabrini Hospital has been a leading contributor to patient recruitment in this database now for several years and developed the software platform on which this was based through the Cabrini Department of Surgery, supported by Let's Beat Bowel Cancer. We believe that any patient being treated for colorectal cancer in Victoria now should be treated at a centre that has universal recruitment of all patients into these databases. There is a subset of patients for whom minimally invasive surgery won't be suitable. Patients with locally advanced extensive T4 involvement of local organs requiring removal of adjacent organs and extended resections usually are not suitable for a minimally invasive approach. Patients with significant comorbidities may not be suitable for a potentially prolonged procedure. Patients who've had extensive surgery in the past and have extensive intra-abdominal adhesions are often not suitable for minimally invasive surgery. And finally, patients who are morbidly obese have a much higher risk of requiring open surgery or conversion from laparoscopic surgery.
A proportion of patients in the order of about 20% who undergo preoperative chemoradiation will have clinical and radiological evidence of complete pathological response with no discernible residual tumour after the completion of therapy. Prognostically, we know these patients do better long term, but naturally the question has been asked as to whether a subset of these patients can get by with chemoradiation alone and avoid surgery. This so-called watch and wait approach after chemoradiation is the subject of multiple clinical trials currently, and long-term efficacy of this and parameters for selecting which patients are suitable for watch and wait are still evolving. In 2020, watch and wait is not part of routine care, and all patients would go to surgery.
Follow-up of rectal cancer. Generally speaking, after patients are discharged from hospital arrangements will be made for them to be reviewed by their treating surgeon and their oncologist or radiation oncologist. Routine follow-up for surveillance for metastatic disease after resection of rectal cancer occurs 6 monthly for the first 3 years and then annually up to 5 years for patients who have not been treated with radiation therapy, but up to 7 years for patients who have had radiation therapy. Surveillance for metastatic disease generally includes liver function tests, a serum CA at each follow-up, and a CT scan annually. Surveillance for metachronous disease with a repeat colonoscopy is generally performed in keeping with national guidelines, which currently mandate 5-yearly colonoscopy.
Stage 4 disease means the tumour has spread through the bloodstream beyond the loco-regional area, usually to the liver, but also to the lungs. The vast majority of patients that have stage 4 disease cannot be cured and are treated palliatively. It has been shown using palliative chemotherapy that we can significantly extend survival time if patients are treated on a consistent basis throughout the length of their disease. There is a small subset of patients that have disease that potentially can be cured even though it is stage 4. This requires complete surgical excision of all metastatic disease prior to receiving chemotherapy. Approximately 10 to 20% of patients will fit into this category, and their survival is significantly longer. Case study number 1. So, first case study, 74-year-old woman with a cancer 14 centimetres above the anal verge. Ian, how would you deal with that?
I think, Gary, the first thing is to make sure, is it a T3 tumour or does it have positive nodes? But most importantly, at 14 centimetres, the MRI assessment and careful surgical assessment will tell us whether it's above the peritoneal reflection. It's most likely to be above, in which case chemoradiation in the neoadjuvant setting doesn't really have a role. But Paul, I think surgery really is the critical management of this.
Well, at 14 centimetres, this is above the peritoneal reflection almost certainly, and for all intents and purposes, this is a rectosigmoid cancer. So T&M staging preoperatively is not nearly so important here. We treat this as a colonic cancer, and in my hands, unless there was some other aspect of this that we're not aware of, this patient would proceed directly to resection.
The next case involves a 38-year-old male with a cancer at 7 centimetres from the anal verge with T3 penetration on MRI. Gary, tell me about your involvement in this case.
This is the classic case where neoadjuvant treatment needs to be used. So neoadjuvant treatment basically means treatment prior to surgery, and it is a combination of radiation therapy and chemotherapy. There are 2 types, long course and short course, and the decision as to which to use depends on what occurs in the multidisciplinary meeting and all of the tests that are done prior to presentation at the meeting. Basically, radiation is combined with chemotherapy, and we tend to use an oral medication, capecitabine now, which is used as a radiosensitizer. Paul?
Well, assuming that this man's fit and well, his sphincter function's okay, I agree that this man would be discussed in the multidisciplinary meeting. Almost certainly if he has T3 penetration, would regard him as being of increased risk of local relapse. He'd go through neoadjuvant treatment, almost certainly long course in this setting. And then depending upon the degree of response that he shows afterwards, for a 38-year-old, even if he had a complete pathological response, personally I would not be advocating a wait and watch approach. Firstly because of his age, and secondly at 7 centimetres we'll almost certainly be able to reconstruct this man. He'll then have a period of time of somewhere between 6 and 12 weeks depending upon his responsiveness and his recovery from the chemoradiation, and then we'd offer him a minimally invasive approach to resection and reconstruction. He'd almost certainly require a loop ileostomy given that he's going to have a lower third anastomosis post-chemoradiation. And as you know, Gary would then make a decision about whether or not this patient is offered adjuvant chemotherapy post-operatively, further adjuvant chemotherapy on the basis of his nodal status. And I think it's important to make the point that whilst the MRI is excellent at picking T penetration through the wall of the bowel, it's not nearly as good at picking nodal involvement. So we don't know yet at this stage whether this guy has nodally involved disease, whether he has stage 3 disease, under which circumstances he would be offered adjuvant chemotherapy post-operatively. We may well, in this man, if he's taking some time to recover after his surgery and he's having his chemotherapy, allow him the full 6 months of treatment before offering him reversal of his stoma.
The other important thing too, I remember, Paul, is given his age, is going to be involvement of the familial cancer clinic and involvement of our psychosocial support for both him and his family throughout this whole process, which Cabrini has very specialised services to support these patients.
Additionally, this man in this setting would be offered immunohistochemistry testing almost certainly on his preoperative biopsy specimens here, because we may not have enough tumour tissue at the time of resection to ascertain whether or not this guy has intact or non-intact immunohistochemistry staining for mismatch repair protein products, which would be, if absent, an indicator of Lynch syndrome. So case 3 is an 84-year-old woman who presented with a lump in the anal canal. She was taken to endoscopy suite for colonoscopy, and biopsies and examination confirmed the presence of an anorectal tumour, and biopsies showed adenocarcinoma. This lady was referred to a colorectal surgeon. A thorough examination under anaesthesia was performed, and this is right on the sphincter mechanism. So in this particular circumstance, there really is no option for this lady to have reconstruction, and in a surgical sense, she'd be offered an abdominoperineal resection, almost certainly by means of a laparoscopic approach. Gary, how would you see the role of chemoradiation in this patient?
I think it needs to be individualised to the patient. The patient is 84. If she is fit and healthy and definitely has a T3 to T4 lesion, then she should be offered chemoradiation prior to surgery. It does reduce local recurrence and extend survival. On the other hand, if she is someone who has major health issues, multiple chronic comorbidities, it may be that we just proceed to surgery alone. The most important thing in all of these cases is that the patient needs to be treated as an individual, and one 84-year-old is completely different to another one. What do you think, Ian?
Gary, I think you've really covered it quite well. The issue really is her physiologic fitness and careful assessment of that, and multidisciplinary assessment by all teams, bringing the decision together at the MDM to individualise her care.
Let me ask you this, Ian. If after completion of a chemoradiation she came back to see me and I examined her and she had an MRI and we deemed that she'd had a complete pathological response, what would you see as being the potential role for a watch and wait in this setting? This is an 84-year-old woman who otherwise would require abdominoperineal resection.
I think it's important, Paul, to reassess her physiologically to see how she's recovered after that treatment. Would she normally be fit for surgery in that setting? But she'll already fall into a very good prognostic group in terms of being a complete responder. So the option of a watch and wait in the approach in that setting with careful follow-up by the colorectal surgeon is imperative.
Case 4 is a woman who presented again with an anorectal tumour. She was referred for colonoscopy. She had a tumour right on the sphincter mechanism, and biopsies on this occasion showed a basaloid pattern of squamous cell carcinoma of the anal canal. Ian, what would you regard as contemporary management for this patient in 2020?
Paul, this is a highly curable cancer, which on staging with both CT and PET will best help us to identify the extent of disease. And studies now over 30 years ago have shown that with combined chemotherapy and radiotherapy, now carefully tailored using very modern VMAT techniques to reduce dose to normal tissues and maximise dose to both the primary tumour, elective nodes and any involved nodes, may result in rates of cure better than 80%. Cure matches local control. So it's important again to manage patients with chemoradiation carefully over a 6-week course, but then monitor them carefully for both acute and late side effects and manage those throughout the course. And do that in conjunction with the medical oncologist and surgeon in terms of assessing the response. In case ultimately, potentially at 6 months, if there wasn't a complete response, sometimes surgical salvage is necessary.
Gary, can you talk about how the chemotherapy for this patient would be different from a patient who had a node-positive adenocarcinoma of the rectum?
So there's a specific protocol for squamous cell carcinoma of the anus for chemotherapy in combination with radiation therapy. An old drug, mitomycin C, is used as a single dose, and then standard fluoropyrimidine chemotherapy is used after that. So it's slightly different. It's not massively different, but I fully agree with Ian that there's really no place for surgery in the primary treatment of squamous cell carcinoma of the anus. The only real role for surgery is in patients that have local relapse, and at that point in time, surgery is the only chance they have of being cured.
The next case is a 64-year-old male with a past history of myocardial infarction and insertion of stents with an adenocarcinoma involving T2 penetration of the middle third of the rectum. Paul, tell us about management of this situation and the complexities of surgery.
Well, generally speaking, in this setting, if he has T2 node-negative disease, then we treat with upfront surgery. But the difficulty, of course, this is a man in his 60s who has known ischemic heart disease. He's had an infarct in the past with stents, and he's on antiplatelet agents. So before even contemplating surgical therapy in this setting, it would be essential that he has a full physiological workup and usually some form of functional cardiac testing. Most of these patients, of course, if they've had stents, will have a treating cardiologist. We'll refer the patient back to the cardiologist for reassessment, and occasionally we'll see that they do need some form of further intervention prior to the surgery. If the cardiologist deemed that this chap was in reasonably good condition, that his myocardium was well perfused and his coronaries were okay, then we'd proceed directly with upfront surgery, and adjuvant chemotherapy post-operatively would be reserved only if it turned out that he did in fact have nodal involvement. The really difficult situation with this guy, of course, will come up if he has, let's just say, progressive triple vessel disease and required further cardiological intervention prior to his surgery. Under those circumstances, we're obliged to sit and wait and watch, and we may in fact bring this patient back to the MDM for discussion about whether we simply treat the patient with either stent insertion or revascularisation by coronary artery bypass grafts, then wait for some weeks until he's well enough to undergo surgery in the usual fashion. Or if the patient is never physiologically sufficiently fit to undergo surgery, we may consider the role of chemoradiation in this setting. So, Ian, I'll ask you the question. If I came back to you and said this guy's going to have to wait 3 months now prior to having his definitive resection of his cancer surgery, what options would there be for potentially short course treatment to tide over the management of the cancer during that time?
Paul, I think short course is an option that really was developed in Europe when resources were scarce, but offers an option for a high rate of local control. But quite often in this setting, we often consider whether there's a role for longer course chemoradiation, simply to offer the greatest opportunity for tumour downstaging and shrinkage. But of course, this may be complicated by his need for cardiac surgery and his fitness for chemotherapy. So in fact, short course may well be an option in this setting.
So there may be the option of short course followed by revascularisation and then definitive surgical treatment. Gary, can I ask you, in a patient in this setting where generally we wouldn't see a firm indication for chemoradiation preoperatively, would you be prepared to consider chemoradiation in a patient with T2 disease if they had other comorbidities that precluded them going straight to surgery?
This is the perfect example as to why we have multidisciplinary meetings. This is a complicated patient with a complicated disease. Rectal cancer is a complex issue and has recurrence patterns that are completely different to colon cancer. I wouldn't feel comfortable leaving him for 3 to 6 months without any treatment at all, and fully agree with Ian that if the option was to give him long course treatment, we would go for that. But if we felt that he was not up to that, we would treat him with short course. One of the things that we often do is we actually make decisions on the run in terms of starting treatment and then dealing with what occurs in people that have poor health otherwise as they go through. One of the things that can occur today, particularly with regards to support for other diseases, cardiovascular, respiratory, diabetes, those kind of things, is that the physicians that look after them can do such a good job that we can actually give them definitive treatment.